Hello, everybody, and welcome to the latest Simply People webinar. As always, I will be hosting. I would normally leave it a couple of minutes just for the stragglers, as I tend to call them, just to join the session. So thank you so much for taking the time out this evening, and I'm sure you will find the session to be of value. The session today will be delivered by Janet O'Neill from the People Asset Management Group. And those that know Janet know that you're in for a treat. Janet is a wonderful presenter, so
thank you.
Give it a couple of minutes and we'll start the session.
I'm blushing
Sorry,
here.
you off then, didn't I? I would offer to sing, but I wouldn't like to put that on anybody, to be fair. So it is gone a couple of minutes, so we're 90 seconds into the session, so I will start for all of those that were on time, and everyone else can just pick up as we go along. So thank you very much for attending today's session. Just a quick introduction for my voice. I am Danny Clark. I am the founder of Simply People. We are connecting a community to improve the physical and mental health and well-being of employees in the workplace. And we do that by bringing together the community that you yourselves will be part of. If you've not seen it yet, we did launch the new community platform last week. I hope everyone has been able to access it and find it of use. We have a number of groups, we have a number of forums and news channels on there. So if you haven't checked out the platform yet, please do take the time to have a look at that. One thing I would say on the platform is please do not ask permission to post. It is not my platform, it's not my community, it's for everybody. So if you have any posts to share, any news to share, events that you think people would benefit from, or indeed specific topics within the groups that you'd like to talk about, please do go in and join. Please do share and invite any colleagues that you think would add value to the community or that would find it of interest as well. It's a cohesive unit, so please do feel free. You don't need my permission. I won't post on your behalf, so please do feel empowered to do that. If you've not been there yet, it is accessed through our website. We did launch a new website today, which is simply-people.co.uk. Anyway, that's enough from me for the platform. You're here today to listen to Janet O'Neill deliver a session on what makes an occupational health report effective. It is a really good session that we've got lined up today, and Janet is an expert in this topic, and hopefully you will have a number of takeaways from the session today. The session will be recorded, as all of our webinars are, and will be available through the platform on the community through the resources tab, so please do check that out afterwards. Listen, let's hand over to Janet. A quick introduction. Janet is the Clinical Nurse Director for People Asset Management. She is passionate about occupational health and sits on a number of boards. She is one of the go-to people for anything related to occupational health and quality that I would personally go to. I can't speak highly enough of her. If you do know her, you'll know what she's about. If you don't, where have you been? Without further ado, let me hand over to the wonderful Miss Janet O'Neill.
Thank you. I'm blushing here. I'm having to fan myself because that was a wonderful introduction. So thank you very much, Danny. And if you don't know me, please feel free to give me a shout on LinkedIn or Facebook, etc. I'm always more than willing to chat to anybody. And the one thing I would say is that I'm learning every day from everybody, and I think that's what occupational health is all about. And I think that's what makes occupational health so special, is that it's constantly growing and expanding and changing. So today's session is what makes an occupational health report effective, and I've looked at it from the angle of actually what is the background to making an occupational health report effective, other than just writing the report. Now, somebody I really admire is Dr. Nerys Williams. She's a consultant occupational health physician and a prolific writer on occupational health, and she states that a good occupational health report is essential to demonstrate a high quality service. So if you wouldn't mind moving on slides. Danny's moving my slides on because I had a little bit of a technical issue. So this is what we're going to talk through today. What is occupational health? Why do employers refer individuals for an occupational health assessment? And what do managers want from the report? When is the best time to refer? The basis of a referral, what a referral should be like, an effective assessment, what does a good report look like, and what to do if the report does not meet expectations. And it's really, we do need to emphasize that a report is a formal communication tool with good information equaling good information in, equaling good information out. So some of this information here is aimed at managers or HR that do refer, but also hopefully you could find it useful if you in occupational health yourself and you want to create some management training on effective report writing. Hopefully it will be of use for you. So if you wouldn't mind moving on, please, Danny. So before I start on this slide, I just want to say that an occupational health report is our packet of biscuits. It's our product. It's what we sell. And if people are not able to see the commercial aspect of occupational health, then we will be falling at the first hurdle, because somebody has to buy us, somebody has to pay us, and that is because we have a product that is useful to people. So if we don't demonstrate a quality a product, then people aren't going to be engaged with us and purchase us, if you like. They're not going to see our value. We've got to be seen as a cost-effective quality product, and we can only be cost-effective if value is demonstrated. Value equals cost effectiveness. So various bodies advise a referral to occupational health, and of course you know those: CIPD, NICE, HSC, ACAS, etc. Usually for sickness absence management, and that includes presenteeism. And workplace health experts say this because they understand that work is the outcome goal, and why we are workplace experts, because we understand what that work is an outcome goal and why work is an outcome goal. We understand the health and safety legislation. We understand the employment legislation, the Equality Act, the data protection. We're able to support employers to understand that interaction between work and health, and we support employees themselves with their own health in work. We're independent assessors, as opposed to the GP, who are their patients' advocates. We use a biopsychosocial model, so we look at the person as a whole and we match that to the risks of the job, so we understand the risks of the job. We have a medical expertise which enables a clinical opinion of workability of the individual based on a knowledge of work and the workplace. And we also have critical thinking skills, which is really important with when we come to report writing. What people have to understand, that this report is based on health. So, and with anybody being referred into occupational health, it must be health issues. So if you don't mind moving on, please, Danny. So we're a speciality looking at how health affects work and how work affects health. And there's actually a number of different professionals. So for example, your nurses, your doctors, your physiotherapists, your psychologists, your psychotherapists, and your physiologists that make up the occupational health team, if you like. What CIPD states, it's forward-thinking organizations recognize that managing their people is just as important as controlling financial and capital resources. So it's about, if you like, that people go out and they do an MOT for their cars and they look after all their equipment, but they need to be looking after their people. When people refer into occupational health, when it comes to writing a report, it sounds simple, but actually it can be quite complicated, because there are so many different variables to consider, such as the workplace, the work tasks, the tasks which might have physical, cognitive, or psychological elements that may be required, what standards of fitness need to be met, for example, driving roles or working at heights, whether there are particularly a particular type of roles with the risks that are there, and that needs to be matched with the person, their beliefs, their social status, what motivators they've got, their family pressures, health issues, treatment, medication, and lifestyle. And that's why it's really helpful in occupational health to have a number of different professionals that can support, because everyone brings a different element to the party, if you like. So if you don't mind moving on, please, Danny. So usually with the qualification, can we go back? Usually with qualifications in workplace health, in occupational health, we're looking at the risks of the work environment on health, as I've just talked about, the effects of health on the work environment. And we provide advice to managers and HR, but we can't actually manage that individual for them. So if you don't mind moving on, please, Danny. So what do managers want from and HR want from a report? And if anybody's got any opinions, I would really appreciate it if you pop that in the chat, because I think I'm looking at it from an occupational health advisor perspective, and so therefore I can assume what a manager, and I can listen to what other people have said. But if there are anybody out there that do have ideas on what managers are looking for, or they are managers and they want to have an understanding, then please pop those into the chat, and we'll go through those at the end. So my understanding is that they want to be able to understand what the report says. They want it to be clear. They want it to be practical. They want it to be pragmatic, something that they can absolutely use. They don't want to be sitting there wondering, oh, well, I don't quite understand what this is saying. What does it mean to me? And then they're left feeling, well, actually, let me just discard that and carry on. They want us to provide advice to them, but they also want advice for the individual, that empowering that individual, giving them direction and signposting. They want that report to be independent. They don't want it to be biased towards the employee, but they also, we don't want it to be biased towards the employer. It needs to be independent. Sorry, if you don't mind. It needs to match the role in the organization. So going back to being practical, if it has no relevance to that role in organization at all, then it's not going to be of any use. They need to answer the questions asked, and I certainly found when we audit reports that commonly clinicians will forget one of the questions that have been asked, and that can be quite frustrating for managers. Next one, Danny. Give a long-term prognosis as well as a short-term. So what's going to be the likelihood of the person coming back into work now, and the support that's needed now, but also in the longer term as well. What could they foresee down in the future? We need to be able to match that advice to the primary role or the substantive role. So understanding that substantive role and matching the advice to that, not making it generic, is what I understand that managers are looking for. Giving them information that otherwise they would not have known or understood. So what I say to people is that if you, as a clinician, if you're reading your report and you need to ask yourself, could the manager have had a chat to their employee and have written that report? And if the answer to that is yes, then there isn't that value add that's required from an occupational health report. We're adding that value. Remembering that it's an advisory report, always, it's not an instruction. We can't tell the manager what to do. We just do not have an understanding of that organization, enough understanding of the finances, the resources, what's happening within that organization to be able to instruct. We are always advising. and make sure that advice is backed up with reasoning and justification. Managers and HR are human beings at the end of the day, and as human beings, we need to understand why we're being asked to do something, and if we don't understand, then it's unlikely that we're going to do that. And just to give an example, we had a client who decided that the report would go back to HR, and all HR would do would be to take out the advice itself, just the advice to, you know, on supports and adjustments, give it to the manager, and then the manager was expected to put those adjustments in place. And what they found is that the managers weren't doing that. They were just looking at the report and saying, oh, well, you know, I can't do that, and just discarding it. But once they had a look at it, had a chat to us, and we suggested that they provide the whole report to the manager, there was a completely different story, because now they understood why we were asking them or making these suggestions, providing that advice. They understood the background to that, and it was just so powerful. So if we're just banging out advice without any reasoning or justification for that, not providing those managers and HR with that understanding, then it's very likely that they're not going to be following up with our advice. And then, of course, that leaves those employees feeling that they've been let down because nobody's listening to them. So when is the best time to refer? Timing is really important when looking at the outcome. The outcome goal is always going to be work, and the longer the person remains out of work, the more difficult it is to return. Even the same with presenteeism. Sorry, I'm going off the slides a little bit here. The longer the person remains with restricted duties, the more likely it becomes a contract change. So we need to make sure that timing to that referral is important. NICE say themselves that there's evidence that accessing interventions early may help reduce sickness absence rates and promote a more sustainable return to work. What we say in PAN, just so that you know where we come from, we always tell the managers to have a conversation with their employee first. It's all about communication. All the evidence is that the most important person in an individual's working life is their line manager. So if they have that conversation with that employee, it's very likely that they may be able to come to an agreement on how that person is going to be coming back into work and when that person is going to be coming back into work. So they should start off the process. And it's only if they're not able to facilitate, or they don't understand the situation, or sometimes it's because it's part of their attendance policy, then we suggest that they refer into occupational health. And in that case, we say refer as soon as possible, because we're able to introduce that work goal. We can start looking at those adjustments and support that could be put in place, or that earlier referral. And as I was talking about, NICE advised that within 4 weeks for long-term sickness absence, and early for short-term sickness absence. And obviously, different organizations have different policies in relation to when somebody would be referred into for a number of occurrences. But you don't want to leave it till somebody's had too many occurrences, and then it ends up being a long-term sickness absence or disciplinary process, etc., when actually we could have maybe ascertained a health reason and supported that individual and given advice on adjustments much earlier. And I've just popped the NICE links in there in case anybody is interested. What we will say is, and what we say is to our clients, is give us your attendance policy as well, because that helps us when we're advising their the line managers, etc. And it helps us when we're assessing an individual to understand what their attendance policy says, how much sick pay people might have, whether there's any facility to refer on to, say, private healthcare, etc. And the same with the health and well-being policy and the drug and alcohol policies and procedures. If we can get those beforehand, then it makes for a far more effective intervention and likely far more effective outcome. And another thing that's, we can always suggest to managers, or if there's any managers or HR on the call, sometimes if you've got an occupational health provider, and especially now during COVID, it's not so easy just to pop into a workplace and go and have a look and see, what somebody's working conditions are like, or how the work is set up. But do videos for occupational health so that we can have a look and see what that workplace looks like. The more information and the more understanding that we have around a workplace, the better it's going to be. The better that the report outcome is going to be, the more practical and pragmatic. You want to move on, Danny? So what is the basis for the referral? Under General Data Protection Act, or GDPR, there is it focuses on a reason for processing. So an occupational health referral is the reason for processing. So we can't effectively proceed without a referral. No referral, no assessment, no report. And it should be as simple as that. And generally, the Data Protection Act or the GDPR are obligations, or what we are focusing on when we're doing referrals and reports. And the obligations state that information has to be accurate and up to date. It has to be collected for a specified, explicit, and legitimate purpose. It has to be adequate, relevant, and limited to what's necessary. And that's really important when we're assessing somebody and we're providing a report. It's got to be enough, it's got to be relevant. But how do we know it's relevant? Because we've got a referral to match it to, and it's got to be limited to what's necessary. So that shows us how important that referral form is when we're assessing someone. And then, of course, there's the Equality Act, mainly around disability for us, and reasonable adjustments, but of course there could be aging, pregnancy, other factors as well. Now, a lot of employers like us to tell them up front whether somebody would be considered to have a disability, and it's not something that I agree with. Actually, I don't agree with us just stating that somebody has a disability. I feel it should be a question that is asked and then we answer, and that's mainly because I feel we should be treating everybody regardless of whether they've got a condition that's lasted 12 months or not, on the basis of how they present. So if they present with a health condition that's less than 12 months and adjustments would be helpful, then obviously we want to be suggesting those adjustments regardless of whether the person is likely to have a disability. I think that's one of the most powerful things of an occupational health report, is being able to suggest those adjustments. Whether they're reasonable or not is obviously up to the employer to make that judgment, but at least we can give them some guidance and support in what adjustments would help that individual to stay in work or remain in work or work more effectively. And that should be regardless of whether they're likely to come under the Equality Act. However, we've got to understand that some employers will have the Equality Act built into their processes. For example, they might have, absences related to disability will be disregarded if it comes to an attendance bonus, or it might be that they can only adjust trigger points if somebody's likely to come under a disability. And then obviously we're more than happy to answer that within the confines of our ability. In other words, we can only say whether they may or they may not be considered to have a disability, unless of course they've got an automatic disability. The other thing about making a standard statement about disability that doesn't sit well with me is that the automatic disabilities are only really MS, HIV, and cancer. And most employers will know if their individual has MS or has cancer, but they may not know if they've got HIV. So putting on a report that this person has an automatic disability might actually tell the manager what that person has. So I'm always a little bit wary of that. But obviously, people have different ideas around that, and some employers may specify that they want to be the report to reflect a disability, and that's obviously a discussion that people can have with the client beforehand. And then, of course, we need to be aware of health and safety legislation, as I said earlier, what risks that person might be exposed to, what risks could they pose in a particular role, and what are the health and safety standards of fitness. So we wouldn't, when we come across somebody, we would have to understand that role to understand whether there are some health and safety standards of fitness and what those standards are. And then, of course, common law duty of confidentiality. We have a duty of confidentiality. And just going back to the General Data Protection Act, it's transparency. So it's in occupational health, we have to be transparent with that individual, and the managers need to be transparent with that individual. That individual should not be coming into occupational health without having an understanding of why they're there, and how that information is going to be used. It generally ends up in an aborted assessment, or a very difficult assessment, if that person isn't aware. So we're always telling managers that they need to make sure that their employees are fully aware, and usually they should be providing consent coming into occupational health. So we have that common law duty of confidentiality, but it's also remembering that we are not writing under Access to Medical Reports Act. We write a management report, not a medical report. So we do not come under that Access to Medical Reports Act, which we've noted some of our clients have made that error. And next, Danny. And not forgetting the clinician's code of practice, so whatever the governing body is, so that might be NMC, GMC, HCPC. And just to reflect back to the different clinicians that I talked about in a previous slide. So for us, we have physiotherapists, that occupational health trained physiotherapists that will undertake management referrals relating to musculoskeletal conditions, and we have a clear parameters of exactly what will go to a physiotherapist. And we do the same with psychotherapists as well. We have clear parameters of what referrals would go to a psychotherapist in relation to mental health. And of course, it's usually the nurses or the doctors that will see anybody in between. But that doesn't mean to say that the physios, the psychotherapists, and we have physiologists as well, couldn't benefit those individuals with early access to treatment or to behavior change support in order to help them to maximize their health and well-being, in order to help them get back into work. And that's why there's a lot of, we have to, in occupational health, appreciate the multidisciplinary team and the multidisciplinary team working with effective occupational health. So as I said in the very beginning, it's good in, good out, bad in, bad out. It's not possible to have an effective report with a poor referral, and therefore training managers or giving managers the tools to be able to give a good referral is as important as having a good clinician writing a report. And it's, we talked at the very beginning about it's a quality report, demonstrates a quality service, etc. But part of that quality service is educating HR and managers on what the limitations are with occupational health, our scope, our remit, and what we can do. And as I said before, it's just as important that the manager is talking to the employee and making the employee fully aware of what information is going in that referral, and what they are discussing with that occupational health, and what they're expecting out of that. how are they going to use it? So we want as much information as possible, how long that person has been in the role in the organization, what sort of absences they might have had. You know, in occupational health, we can easily gauge from somebody's absence history. So, for example, if you get somebody who's been in the organization for 5 years and they've never had any absence, this is their first absence, immediately you're thinking, gosh, this is going to be quite significant. Or if you get somebody with lots of different absences and they're all musculoskeletal based or back based, you're automatically thinking, oh, we need to do some investigation around here for a chronic back problem or something else. So it really gives the clinician a bit of a heads up and helps to direct the consultation effectively. So if any managers or HR are out there listening, please provide us with the absences and the reasons for those absences. We absolutely want to know what is the condition or what conditions there are, and generally that can come from the sick note or fit line, as they say in Scotland. That helps us to be able to do that prep, to do that research on that condition, because obviously in occupational health we come across many hundreds of different conditions, and some of them, you know, the more common ones we all know really well, but sometimes we may need to go out and do some research, and we have, and hopefully those clinicians out there, we have our validated information sources to go out and find out. We want to know what discussions have already gone ahead with that individual. Have they already talked about adjustments, and what adjustments have been agreed upon already or discarded? You know, what discussions have been had about the difficulties that that person might have had in the workplace. So therefore, that would include any concerns that have been raised by the individual. Are they you know, have they raised any work-related concerns? Have they raised any issues in relation to their working hours, shift patterns, colleagues, managers, anything like that? Because that gives us a bit of a heads up on what are those work issues that may be impacting on the individual. Remember, we talked about the biopsychosocial model. So we're looking at the person as a whole, and of course, work is a huge part of that individual's life. So what impact on work that has already been noted? So sometimes we have managers say, well, not noted, you know, I haven't noted any impact on work. And then you're thinking, well, surely there's something that's, you know, caused you to refer that person into occupational health. And sometimes that might just be sickness absence. Actually, they've just not been in work. So that's an impact on work in itself. Understanding the job. So having a job description is incredibly useful, and sometimes we have our clients that will give us the job descriptions up front when they become a client, and then that's really helpful for us to get to know the different roles that people are working on and what that includes. And sometimes managers will include sort of welfare notes that they've had, you know, with of documented conversations that they've had with their employee, and that's really helpful because it's often that they've discussed medication on that, they've discussed the health conditions, whether they're having any treatment, etc. So that's giving the occupational health clinician that heads up on what the managers already know. We don't want to hide behind confidentiality if the manager already knows. So understanding what information that manager has already is so useful. And of course, any other information that the managers might have. So they may already have been given a GP letter or a consultant's letter. They may have had previous reports from elsewhere, from other providers that we haven't had yet. There might be sick notes. So any extra information that they might have that will help to give that clinician that extra bit of understanding. If we don't know that the managers have got that, then we may be discussing the information that the manager is already aware of because they've got that report. So then that's not adding any extra value. Whereas if we do know, then we're able to elevate the information in that report that one layer up. Absolutely need to know what adjustments are already in place, but also need to know what adjustments are possible. Is, if something is absolutely not feasible, then we need to know that. But if something is feasible, then that gives us a sort of an idea of how to make that those adjustments and that advice bespoke to and practical for that workplace and for that manager and that individual. And of course, if there's any critical elements of the role. Now, sometimes we know, so if we're working with somebody who's a paramedic, we know that they're going to be a blue light driver. We know somebody who's an active policeman, we know that they might be a blue light driver. We know the conditions that they might have. But some things we might not know. So, for example, for a paramedic, it might be that actually, especially if it's a new client, we need to learn that they can't work part-time hours on an ambulance. The ambulance can't just stop in the middle of the middle of a case and just say, oh no, we need to get our other one of our employees back, so we're just not going to carry out we're not going to attend that call. That's just absolutely not feasible. So we need to know the nuances of a job, the shift patterns. We don't want to be suggesting a phased return to find out that they work 1 day on, 9 days off, 5 days on, 2 nights, etc. And our suggestion isn't going to fit that, and in any shape nor form. So any information that we can get to make our reports more practical is what we're looking for. And that's why upfront conversations with employers, and of course if you're working in-house as an in-house occupational health provision, that is actually a lot easier because you have more ability to go out and see what the individuals are doing. If you're in a provider like ourselves, you have to generate that information. You have to work out how you're going to get that information to those clinicians so that it's quick and easy for them to pick it up and they get an understanding. Even if it means like we've gone out and done site visits as a one-off to get a feel, especially with ambulances. We've been out on fire engines, etc. We've had half days out to get to know the clients. And videos, as I said, are really useful. Familiarization webinars or familiarization e-learnings we've done in the past to get to know the clients. But it is essential to get to know the client, the customer, the employer, the workplace. Next slide, please, Danny. And of course, we believe strongly in triage in PAM. So, and I don't know about other occupational health providers, but I'm sure they do triage. But triage is really useful way of screening those referrals, making sure that they go to the right clinician, but also that we've got the right information in that referral to be able to provide a good report. And of course, I've already talked about transparency and just remembering that employees, if they're in the consultation and they feel that they didn't understand, they can just withdraw consent and walk out of that consultation at any time. Next slide, Danny. So what is an effective assessment? You can't have an effective report if you don't have an effective assessment. So here I love this graphic on the biopsychosocial model, which I've mentioned already several times. This one particularly is on mental health, but of course we do need to be able to assess that person for the biological, what is the health issue that's going on, the medication, the treatment that they might have had or is ongoing, the consultants they're under. Of course, their psychological, their beliefs, their health beliefs, behaviors, their coping, their self-esteem, their confidence, their social and environmental factors. We often see that people who live with someone when they've got a mental health condition actually fare better than people that are on their own because they're quite isolated. And musculoskeletal problems, we generally find that people who live on their own do far better because they have to do things themselves. but also social. Are they caring for someone? Because we're all just one human being. And so if they're trying to work and they're trying to care for someone and they've got their own health issues that they're trying to cope with, you know, there's only so much that a person can stretch to. And in occupational health, we look at flags. So red flags, of course, musculoskeletal red flags, those issues which would be urgent, immediate, psychological, or musculoskeletal, or it might just be the health conditions themselves. So, for example, somebody's got cancer, they will have to cope with the medication, the treatment, depending on what they're on. Then there's yellow flags. So yellow flags are those psychosocial elements that we talked about there. What are their health beliefs? What are the beliefs of their family? You know, are they willing to take on board suggestions and advice from us? Are they willing to have that sort of behavior change? You know, are they distressed? Are they unhappy? Have they got poor coping strategies? So we look at a lot of elements around yellow flags. They're probably one of the most important factors that we look at, people's motivators. And then blue flags and black flags around the workplace. You know, how does their work factored in? What are the support measures that are out there for work? You know, that's would take into place shifts, you know, whether they've got support at work, all of those kind of elements. So what we're looking at we're looking for the barriers to work, and they're not always health. So although we say that you need to refer somebody in for health issues, we generally don't deal with non-health issues, but we do need to understand what barriers to work there are that may not always be health. And unless we assess the person as a whole, we're not going to be able to provide a useful report. And just a few factors on there that hopefully you've had a read in that infographic that are really important, like cultural factors, as well as health inequalities, etc. So what is an effective report? So an effective report gauges the audience. It's written for the audience. So you've got to understand who the audience are. There's not much point in writing a detailed report about the condition to a health professional who already understands that condition. That's only going to put their back up. So it needs to be gauged. The language and how it's phrased needs to be gauged to the audience. It should be succinct as possible. If you're going to waffle on a lengthy report that's lots of waffle, you're going to find that the manager's just going to switch off. They're not going to want to read it. Lots of managers now are up against it. You know, they're trying to make decisions with not a lot of time. And some of them may not be good people managers, so they'll just if they don't get the point fairly quickly, they might, you know, lose the wish to actually read and understand the report. It needs to be work focused. So it needs to be focused on those barriers to work. It needs to be clear, understandable, and precise. And I'd strongly recommend anybody who's a clinician on here that doesn't already use plain English to have a look at plain English. It's a really useful website and gives great suggestions on how to make longer sentences more shorter and more precise and get the point across clearer. Find it very useful. And then make it bespoke to the individual, not copied and pasted. And that doesn't mean to say that there aren't some standard phrases that clinicians might use. Certainly we have some standard phrases because that helps with the legal situation, if you like. But it's about making sure that it's bespoke to that individual. It needs to match that person and be relevant to that individual. it needs to give a background to the current situation, so to give the manager a bit of understanding of what's going on with that person from a health perspective, and of course flagging up whether there's any work factors that they may not be aware of or they are aware of. And often that's because the employee wants to be heard as well. They want their voice to be heard within that report. It doesn't mean to say that you're just phrasing the report on what they want. You're just flagging up what the issues are. It needs to be an independent opinion. We need to make sure that we are not the employee's advocate, but we are not the employer's advocate, and we are not following what the GP has said, unless obviously it's appropriate to follow what the GP has said. And this is, I feel, is really important, because this is where our added value is. We are providing an assessment of that individual, and therefore we are providing an independent opinion of that individual based on the information that they've given us on their health and the job and the role that they have. And as one GP said to me, if my patient tells me that, I have to believe them. And if they say that they can't go to work, I have to sign them off. And that's what a lot of GPs feel, because they are their patient's advocate, and rightly so. They should be their patient's advocate. We're the ones that are expert in work and health. And sometimes if we don't get a clear understanding of what that health issue is, so therefore we're not able to give a good advice and recommendations, then we may need to go off and get a GP report, a consultant's report, or speak to the practice nurse, or go to the DVLA, or and go further out and get further medical evidence in order to be able to give that independent opinion. We need to justify the advice. As I said before, the advice, if we don't justify and we don't give managers that explanation, and HR that explanation of why we feel that those adjustments may be of help, then we're not giving them the tools to be able to make those decisions. And I feel quite strongly about that. We've got to give them the understanding of how we reached our conclusion, if you like. We need to make sure we describe the barriers and how these can be overcome. Remember, work is the outcome goal with our reports, and we need to be pragmatic. If the person's not going to be coming back into work, we need to state, the person is not going to be coming back into work, and try and make it as clear as possible. Always add value by signposting. Signposting and providing individuals with the tools to empower themselves and to improve their own health. I always think it's a two-way street. The employee needs to do everything that they can in order to be able to maximize their own health, as well as the manager needs to, where feasible, do what they can in order to be able to support that individual. It's a two-way street, and part of that is by giving the manager's advice and giving the employee the advice and signposting. And it may be that actually you can refer people on to psychological services or physiotherapist services. And I talked about we have a physiology service for support with behavior change, nutrition, exercise, etc. But obviously you may not be able to do that in your organization, but there may be external that you can refer on to. So I think whenever you are assessing an individual and writing a report, having an understanding of what signposting you can do, to hand is really useful. And don't forget to answer all those questions that were asked. And for managers, they should be ensuring that they receive a report with all the questions asked. Just as a manager, making sure that you understand, or managers and maybe HR understand, that the more questions that they ask, the less precise the report is going to be, especially if those questions are duplicated but just couched in different language, which is something that we see. Actually, that detracts from the clarity of a report, and it's also a reminder to any managers or HR out there: the more questions that are asked, the longer it's going to take a clinician to be able to assess that individual and write that report. So that will need to be factored in. Making sure that the advice relates to that role and that organization, understanding that role and organization. Somebody once said to me, we can just suggest any adjustments because it's not up to us to decide whether it's reasonable or not. But actually, I don't agree with that point of view at all. I think that we've got to try and bespoke to that organization and to that role as far as we possibly can. And that means getting an understanding of that organization. We need to understand that managers are going to be using that report, and if they have to sift through loads of different suggestions that aren't in any shape nor form practical, they're going to lose faith in occupational health and the report. Always make sure that you describe next steps. So, for example, if you can't answer all the questions because you don't have the answers yourself, how could they be answered? Could they be answered by perhaps a further assessment? So maybe a functional capacity assessment, or a psychological assessment, or a neurodiverse assessment, or a display screen or workstation assessment. What steps could help that employee, but also what steps could help that employer? Things like you may want to suggest a stress risk assessment, and I often suggest a stress risk assessment even if the person hasn't got work-related stresses, because if somebody has a significant chronic underlying condition that they're having to manage on top of managing a full-time job, then their resilience to normal work-related stress is going to be reduced. So if those are identified quickly, if they start finding them too much and that's identified fairly quickly, then that can actually stop that person deteriorating and then ending up in a situation where they're having to have time off. The RAP plan is also an extremely useful tool for both employees and employers. And if anybody out here is not aware of a RAP plan, then Mind do a great guide for employees and employers. Theirs is called WAP, Wellness Action Plan. We call ours RAP, Wellness Recovery Action Plan, and there's certainly a number of organizations that have actually built the RAP plan into their attendance management and their health and well-being policy. So understanding whether organizations have that is really useful. And also who else you could refer on for support, for example, Access to Work or Able Futures, or perhaps you have an internal neurodiversity service like we do, or perhaps there's Concept Northern. There's quite a few different organizations that you can refer on for workplace coaching and support. And just remember, as I said before, the advice that we give or the advice that should be received is not an instruction. Our standard phrase is if operationally feasible, but other people use standard phrases like it's a management decision on whether this is can be this advice can be put in practice. And it's just advising that actually they still need to make a decision on whether that's practicable for them in their organization. So what should managers do if they do get a report that they don't like? Complain. We always say don't accept a report if you do not understand it, or you could not use that. Because how do occupational health gauge that they're doing a good job if nobody ever tells them that their reports can't be used? Obviously, it has to be practical and sitting down and having a discussion with managers on actually what are the limits of occupational health, which hopefully I've described here today, that occupational health can only work within the confines of their scope of practice. and we don't have a crystal ball, or we don't have a magic wand to be able to say precisely in every situation. But if a manager or an HR don't flag up that they don't understand the report, or it's not of use, how can we evolve and change our practice and improve and get them something that they do need, or gain an understanding that they need some management support and training on how to make a good referral, perhaps, or how to utilize occupational health effectively. So what I would say to the manager is, get occupational health to go through the report with you, understand the limitations of the advice, tell them what you feel is unhelpful. Remember, you're a customer, and that is a product that you've paid for, but also that we are professionals that are bound by our own clinical governance. Listen to the explanation, let them learn from you and what you need, but also you to learn from them. So it is about a relationship. A really good, effective report, an effective assessment comes from having a good relationship with occupational health. And that means talking to occupational health. It needs to be productive within the confines of legislation and best practice. Next slide, Danny. Okay, so in conclusion, a skilled occupational health clinician gives a good report, or should give a good report. There needs to be clear communication to the employee. It needs to be a good referral that's timed well with clear questions. It should have plain English, succinct where possible. Obviously, if there's multiple conditions, it's harder to be succinct. Be clear and pragmatic, justified, and of course evidence-based. We need to have our evidence base. Independent. Answer all the questions with the timeline and prognosis where possible. I forgot to mention timeline before, but actually timeline, even if it's an approximate timeline, is really useful for managers to understand and have put in their head when they should be catching up with their employee next and discussing with their employee a return to work. Make sure that a good report signposts and makes suggestions of what could be helpful and provide advice. And of course, don't hesitate to ask if unsure what the referral should say, or complain if the report does not meet expectation. There's no, I don't think there are any occupational health professionals that would mind a manager phoning up and saying, how could I make an effective referral so that you can provide an effective report. And then I think the next slide is just some references and further reading if anybody is interested. And of course, Danny did say he's going to make the slides available. And so that's everything from me, everybody. So thank you so much for listening. I can't believe that there's only 3 minutes to go.
Thank you so much, Janet. That was really interesting and really effective. And for those of you that have seen before, you notice that I have had a trim. The beard's gone. So I am still the same person. Thank you so much, Janet. Sorry to bore you with my usual rubbish jokes at the end. So thanks so much for attending. If anyone has any questions, please drop them into the question box, and I will pass them across to Janet to ask her to kindly answer them. That was really informative. I think most of the questions are a really great presentation. Thank you so much. It's been really beneficial. I think the big thing to say is that it's about support and understanding what we can do to improve, and also understanding the limits. I know that Janet mentioned before about disability and reasonable adjustments. If you do have interest in that area in particular, we did have a session a few weeks ago with Jodie from Thrive Law around that specific topic. That is available on the platform, so you can go back and watch that through if you do have any questions around reasonable adjustments and disability discrimination, etc. We do have a HR and employment law group as well, so that is run by Jodie and her team. So if you have any questions around that topic in particular, please do feel free to ask it within the forum or the feed within that group, and they will come back to you as with any suggestions. It won't be able to provide legal advice because it is about specific, so you would need to do that off the platform, but their contact details are through there. Hope that everybody found that of interest. You may not be aware that we do run a number of events. On the events tab through the group, you'll be able to have access to those. I think the next one is tomorrow at 2 o'clock, which is our speed networking, speed networking session, where people will meet at least 6 new people for 5-minute sessions. And then next week, we have our long COVID clinician peer-to-peer support group on Monday night. So if you are involved in the long-COVID pathway and you wish to discuss that with your peers, we have that running Monday evening. And then on Tuesday, I'm running a principles of risk assessment. So you will get to hear me deliver a session. For those of you that are interested, they are all available through our platform. So please check those out. We do have lots of events coming up. So check out those that you find of interest and sign up if you'd wish to attend. The principle of risk assessments one on Tuesday will be interesting because it's me delivering it, and I'm going to give you my views and perspectives on risk assessments and how we can improve an effective risk assessment. So it's more than just a tick box. It's like Janet was talking about, an effective occupational health report today. Risk assessments are meant to be valid, they're meant to be relevant, and there's nothing worse from a health and safety practitioner's perspective or my perspective than just having something that's pulled off the shelf, dusted off once a year, and then just gone through. Meaningless or not really adding much value. So hopefully what I share next week will bring that into a bit of context and relevance. But thanks so much for attending. Janet, thank you so much for your time.
That's all right. Can I just say that I attended those sessions from Jodie, and I absolutely recommend people to listen to them. She is really, really great. They're fantastic. And I'm signed up for your risk assessment.
Hey, we have a person. That's amazing. No, I think we got a good number. Thank you so much. There is a question. Sorry, Janet, just quickly. Christiana's asked if there's any resources that can assist with suggesting timelines of recovery for things such as sciatica and back pain, resulting in limited lifting ability. She finds that element quite difficult to navigate and relies heavily on physio's advice for management referrals.
Yes, and that's, I think that's hit the nail on the head. Having access to physios is absolutely excellent. There is, I don't know, BMJ e-learning have free e-modules, and they have a free e-learning on mechanical back pain, which I think will be, which is really useful. And the problem is BMJ is not that easy to get to their free modules. But what I do is I email them and say, you told me it was free, so you better give it to me free. And then they do give you access. But they make it as hard as it possibly can for you to find it free, even though it is free. So I would strongly recommend going to BMJ because they do have all of their sessions are based on NICE guidance, and they have excellent ones on mental health, as well as the mechanical back pain. They've got a free one on occupational health as well, if anybody's interested. But there are some also webinars from physiotherapists. So I know, for example, Jane Johnson, who works for us, she's an author, an MSK author, and she does sessions on sciatica, and I think she's doing one for IOH as well. So it's worthwhile just having a look out for that. But yeah, at timescales, I've known somebody who was a bodybuilder who recovered within a week because he was so fit. But obviously, and the other thing you can use is the Keel Start Back tool. The Keel Start Back tool is really good indicator tool of whether somebody will likely recover within the normal 6-week period, or whether it will go on to become chronic. And it is a free tool, and Keel, K-E-E-L-E, from Keel University.
What I'll try and do, Janet, I'll try and get the links to those resources that you've mentioned there, and I'll post them onto the platform so that within the event that people can access those.
All right, hopefully that's helpful.
Yeah, really helpful.
Brilliant.
Amazing. Thank you so much, everybody. Thanks for turning up. The recording is available again on the platform, as I say. There will be an app coming soon in the next few weeks. Hopefully, we're just waiting. I say hopefully, we're just waiting on Apple and Google Play to accept the app as a proper app, so it can become available through the store. But we're expecting that to happen in the next 2 or 3 weeks. So check out the post for that so you see an update on that. And that then just means that you'll be able to log in using Facebook accounts or LinkedIn accounts, but also have the app so it's easier to navigate on your phones. I'm just filling now whilst attendees while you are leaving the session today. And I don't like kicking people out, so I normally just try and fill at this stage. It would be really good to see people on the session tomorrow. Again, I know that quite a few people do find it of value. So we have people from all different backgrounds that attend those sessions. We have sales coaches, we have HR, health and safety, occupational health nurses, advisors, physios, doctors as well in the past, all attended, and it's generally a good group.
There is actually a lady in there from Able Futures, and she can describe, because I mean, I don't know if anybody else knows here that Access to Work obviously provides support to individuals with disability, but they refer on any mental health cases to either Employ or Able Futures, and they can provide support for individuals up to 6 months, and I've known even they've been able to extend it up to 18 months in the past for mental health in the workplace. It has to be accessed by the individual, but it does mean that there could be some with the individual's consent, there could be some communication with that individual. And also, don't forget, I've talked about all the other specialities, but we mustn't forget occupational therapists are fantastic. And they can often do workplace assessments and coaching. I know we use Concept Northern for neurodiversity, and they actually even will support the client with getting funding from Access to Work for neurodiverse conditions. So it's just, as I said before, making sure you understand who you can refer on to and what sort of tools there are out there.
You know what, Janet? I think you've hit the nail on the head. It's knowing what's available, isn't it? And knowing the limits of who is limits of our own competence and who we can then pass the information on to or access. And I think that's part of what it's about as well, isn't it?
Yeah, absolutely. And we are blessed because we do have so many specialisms that we can refer into that are focusing on work. And to be fair, work is coming up on the agenda, is moving significantly up on the agenda. So, I mean, I'm certainly seeing a lot more organizations now turning to work, or organizations being developed that are focusing on work. So people are beginning to realize that work is a huge part of our lives, and it's a huge part of the economy. And if you don't if you don't keep work going, then and people in work and working well in work, and by well I don't mean just performing, I mean healthy and well in work, then actually it has a negative impact on the economy and the country as a whole.
Yeah, absolutely.